Hi all, thank you for joining. We're going to give other participants just a few minutes to start. So we will get started in about 5 minutes. So thank you for your patience. Hi all, thank you again for joining our webinar this morning, afternoon, or evening, depending on where you are. I'm Miriam Khan. I lead communications for Gradient Health Systems based in New York. I just wanted to get started with a few housekeeping tips as we get started on this webinar, and then I'll turn it over to our moderator. If you have any questions during the webinar, please use the Q&A feature to ask. We will do question and answer at the end of the presentation. You might have seen that the webinar is being recorded. You'll receive a link to the recording following the webinar. And if you don't, it's also available on our website at gradienthealth.org under our training page or on our YouTube page as well, Gradient Health Systems. And as always, if you have any feedback, have any questions, any ideas for topics for us to cover at any of these other webinars, please email us at gradienthealthsystems.org. For now, I will turn it over to our moderator, Dr. Papicho, who will be taking us through this, the outline and the introduction.
Hello, good afternoon. Am I audible?
Yes, we can hear you.
Oh, thank you. Good afternoon, good afternoon, our participants. We welcome you to today's session. We are discussing principles of induction in pediatric anesthesia. Our roadmap for today's presentation will first talk about anatomy and physiological consideration. We'll also discuss the requirement for pediatric induction, and then follows option for pediatric induction. What are the different options that one can have for him to induce the pediatric patient coming for anesthesia? Safe approach for pediatric induction we discussed as well. After you choose the method that you want to induce, is it the safe approach that you would choose based on the type of patients and type of surgery that you have? Challenge of pediatric induction. As any science, there's always a challenge that you have to anticipate, and then you prepare how to go against it. And common causes of adverse events during induction. So these are the points that we are going to discuss. And for discussion of this topic today, we have two good pediatric fellows. The first to discuss will be Dr. Jerry. Dr. Jerry Mwansa is a fellow in pediatric anesthesia at the University Teaching Hospital in Lusaka. He will take us through the first part. Dr. Jerry, you are welcome.
Thank you very much. Yeah, so my names are Jerry Mwansam Sankabala. Yeah, so I'll take us through the first part of our presentation. And that is the overall overview of anatomical and physiological consideration of pediatric patients. So I just want to check if I'm audible enough.
Yes, you are.
All right. Okay. So this is a very, very important presentation. It's important in that anesthesia of patients is very special, if I would put it that way, because the pediatric population is a very special population. And interventions that are done in terms of drugs that are given, procedures are not standardized. So they will always depend on a particular, it will all depend on the age, as well as the weight, and of course, comorbidities, of which some of the comorbidities are not known, as these are just children and they tend to be discovered during these interventions. So they are a very special group. Okay, so in terms of anatomical and physiological considerations, I'll start with the respiratory system, as part of the respiratory system, which is the airway. So when we are inducing pediatric patients, we take a lot of things into consideration. So one of them is that they have a relatively larger head compared to adults. So the larger head, of course, being compared to their trunk. And so if you put them in certain positions like sleeping with a face up, which we call as a superimposition, it becomes difficult to maintain their airway. And that is the trachea, all the way from the nose and the mouth into the trachea. So they mostly tend to close their airway, as the larger head would make them tilt, almost like they are bending towards the front. So that has to be put into consideration. And so when we position them before induction, we make sure we put some form of support like pillows, and put their head in a neutral position, support the head so that the airways are maintained, the patterns of the airways maintained. The other reason is that their tongue, which is found in the mouth, is relatively larger. And a larger tongue would mean that if they are given drugs that would make them go to sleep, they are maybe sedated or anesthetized, they lose control like any other person of the ability to move the tongue to a position where they are able to breathe on their own. And because they lose that ability, they easily block their airway. And because their tongue is larger, the airway is easily obstructed. So that is put into considerations as well as we are giving interventions to them. In addition to this, because they are immature, they are growing up, so their airway is actually narrow as well. So basically the trachea and the rest of the respiratory tree where air passes, it's narrow. And what this means is that any form of obstruction, even just minimum obstruction, easily completely closes the airway. And we are talking about secretions as they are put to sleep. We're talking about inhalation of maybe foreign materials. And this would also explain why children would choke even on just a peanut. A peanut would actually close the airway because it's very narrow. Yeah. And with this, certain conditions like allergic reactions, with severe allergic reactions like anaphylaxis in theater, easily compromises the airway because just the minimal swelling would completely close their airway. So this is very important. Yeah. Anatomically, the first part of the trachea, the larynx, the glottises are different from adults, so it's more positioned higher and it's more anterior. And this, when it comes to instrumentation, when you want to visualize it for intubation, it makes it a bit difficult. All right. Then, when it comes to the rest of the respiratory system, the lungs, where gaseous exchange takes place, are also, of course, smaller because they are relatively small. They are immature. They are growing up, and the smaller lungs are also less compliant. All right, and this makes them, of course, be more susceptible to injury. So it means if we are pushing air in them and we push air with a lot of pressure, we can actually easily damage their lungs because of that increased compliance. Yeah. So in addition to this, their chest wall is also a bit more compliant. Yeah, because their muscles are relatively weaker. Yeah. So they can easily get damage from either pressure from the air that we are pushing in, or indeed the volume of air that we are pushing in. And so even when ventilating these patients, we really have to be careful with the amount of pressure that we are pushing in their lungs and the volume that we are pushing. Yeah. Then their their functional residual capacity is basically just reserve. So it's reserve in a way. Anyone who stops to breathe should have reserve for oxygen in their lungs to continue being used. And this is what basically functional residual capacity is. And for children, this reserve is very minimal, which means that if we put them to sleep, we've got very limited time for us to secure the airway and oxygenate them, because the little oxygen that is in this, the oxygen that is in this little reserve easily finishes and they get hypoxic. So this is very important. Then in addition to this, their oxygen demand overall is also relatively higher, right? And basically for a lot of different reasons, but physiologically we know they are developing, all right? So they are growing up every second. Their cells are functioning every second. And so they've got this increased demand to use up the nutrients that they have. And with this, they need oxygen so that they become they grow and become mature. And so their metabolic rate, the time that they use, the amount of time that they use to get energy from all the nutrients that they have is quite high. Yeah, and so they need a lot of oxygen. So if as you can see, in someone who can't reserve a lot of oxygen, but then their demand is also high, it even puts them more at risk of completely running out of oxygen and developing hypoxia, which is lack of oxygen. Yeah, so that is important. Yeah, then when it comes to these other systems like the cardiovascular system and the central nervous system, we see a similar trend. It's always about immaturity. Yeah, and so you find in the cardiovascular system, there are so many things that we can look at. But most importantly, the heart rate, the number of times the heart beats per minute is higher in children. And you see that with even very small children, it's way higher. And as a child grows, the heart rate keeps coming down. Yeah, and the reason for this, of course, there would be other reasons depending on the comorbidities of the patient, the state in which they are in, their physiological state at the time you are seeing them, because we are not just talking about normal children, we're also talking about children that are sick and all that. But physiologically, the heart rate is higher so that they compensate or they make this demand that I just earlier talked about be more feasible, like they should get the nutrients throughout their body. The heart rate is really because of the immaturity of the heart muscle. As we know, the heart is a very big, strong muscle. And the bigger it is and the stronger it is, the more powerful it's going to be pushing blood out of itself, because it's a pump. It's the one that is pushing blood out there. So in children, this muscle is immature. And so that ability to like contract with enough strength to push out blood is not as good as how it is in adults. And for blood to get out there, it mainly depends on two things. It's the force of contractility that we have here, as well as the number of times this contractility is happening. And that is the heart rate. So the force of contractility results in what is called stroke volume, the amount of blood that will be pushed out. But then the number of times the heart will pump also contributes to this blood being pushed out. So in short, what I'm saying is that because their force of contractility is not as good because of the maturity of the heart, they they tend to work on the heart rate. They tend to depend more on the heart rate to provide for this cardiac output, so to say, the amount of blood that is being ejected so that it supplies other tissues. So the heart rates will definitely be higher. Now, this has an implication on us recognizing things like arrhythmias. So, of course, which are called dysrhythmias. So, abnormal electrical activity of the heart. It's sometimes difficult to like recognize them and also to manage because their heart rates are just way high. Yeah. The other thing is about the amount of blood that they have. All right. So the amount of blood is actually smaller in volume in relation to their weight. Yeah. So that you find newborns who have like 90 mils per kg, and as they grow, this decreases to 80, 85 until 70 finally when they reach adulthood. So relatively to their size, their blood volume is quite small. And so this should also be in our mind if any surgical intervention is to be done on them, that any small amount of blood that they will lose will easily compromise their function. So that is important. Yeah. So like I mentioned, cardiac output will also definitely be high because of this high demand. Yeah. And the high cardiac output means that they can develop cardiac failure, and it is very difficult to manage cardiac failure in these patients. So any just small drop in this cardiac output, and this is the amount of blood that is being ejected in a cardiac cycle, so in a minute. So any compromise, any small compromise in the amount of blood that is ejected in a minute in the heart will definitely compromise them, and it will be difficult to like push it to its normal state. In terms of the central nervous system, again, it's just about immaturity compared to adults. So the central nervous system, which is the brain, the spinal cord, is a very, very critical, very, very important area in the body, as it is involved in everything that the body does, if I can put it that way, all the most important functions. And so it always needs to be protected. So protected from a lot of things, including infections, toxins, yeah, and drugs. All right, the drugs that we use in theater. So it is actually protected from these drugs, and you can't a child can't just be infused with drugs and all the drugs go into the central nervous system at once. So there should be a bit of regulation. So this protection is by what is called the blood-brain barrier. So it's a barrier that will protect the central nervous system from the rest of the body. Yeah, so now this blood-brain barrier, of course, it doesn't offer total protection. Yeah, it will allow certain things to pass through. All right. But in children, you find that the amount of things that can actually go are quite more, or if I can put it that way, as compared to adults. So in short, it's immature, and so anything that would actually we should something that shouldn't actually pass through the blood-brain barrier can sometimes pass and can compromise them. As I've mentioned, it's a very, very important area. So when it comes to our practice, like when inducing patients, drugs can easily cause toxicity in our patients, as they can easily penetrate through the blood-brain barrier. Then because of the immaturity of the brain as well, there will definitely be an increased demand, as these are children, they are growing, they are learning new things, so their brains are developing at a very faster rate. And so this development requires a lot of nutrients and energy, and you see that there will be a lot of a good amount of blood flow to the brain. And so you find that their brains will have very good blood flows. Now, this will have an implication on some of the interventions we do, and because these brains can easily develop brain edema. So this blood that is going there will of course be blood vessels, but with some pathology, some form of compromise, this blood, the fluid that is in this blood, can easily leak and go into the outside of the blood vessels. And this is what is going to cause brain edema. So because there's an increased amount of blood going to the brain, there's a very increased risk of these children developing brain edema. Yeah. Next slide, please. Yeah, and it doesn't end there. Like I said, immaturity is every part of the body is developing, and so we see the liver, the kidneys, which are most involved in metabolism of drugs that we give to these patients, and because they are immature, this population are at a very high risk of developing toxicity because of mainly because of what would consider as overdosing. Yeah, if we do not give drugs appropriately, kidneys will get overwhelmed, the liver will get overwhelmed, and it can easily cause toxicity. Of course, it's not all the drugs, but most of the drugs would definitely cause toxicity. And this immaturity of the liver and kidneys is even more pronounced in children that are born prematurely. Yeah, you will get to see compromise, very easy compromise. And so there are a lot of drugs that are actually totally contraindicated in most of our patients just because of the immaturity of the liver and the kidney. Yeah. So children overall have got a higher body surface area to weight ratio. So compared to their body size, the surface area of the bodies is, if comparing the two, is not as it is in adults. Yeah. So the body surface area being higher means that the ability to lose heat is more. It's almost as though their body surface area is more exposed, if we can think it in that way. Yeah. So they are prone to losing heat quite fast. Right. And so when we are taking care of them, we must make sure that they are well protected. Yeah. And in addition to this, also the ability of them regulating their body temperature. They lose heat. If an adult loses heat, they will find a way of regulating their body temperature through shivering, so that they generate heat from the muscles and such kind of mechanisms. For children, because of this immaturity I'm talking about, it is very, very difficult. So you see that even in the higher centers, like the hypothalamus is part of the brain where regulation of this temperature is done, it's not that matured. All right. And so they find it difficult to actually interpret temperature very quickly and develop interventions to deal away with very low temperatures. Yeah. So it is very difficult for them because of the immaturity. And in addition to this, they've got a higher water content. All right. Now, a higher water content means that if they develop some form of compromise, the pathology or because of our interventions of anesthesia, this water that they have, which is larger in amount, relatively larger in amount, would actually shift. So it would shift, and what we're talking about is like the example I gave, water shifting from the bloodstream going to the brain tissue, causing brain edema. This can happen in other tissues as well. Yeah. So we've got this water shifts, and this will definitely compromise with their physiology. So the water shifts will also compromise on the ions that they have, like sodium and all this. So the electrolytes will also be compromised. And this, of course, will be very problematic in managing of our patients. So every time we are intervening, these are some of the things that we look at, and we make sure we understand them. Yeah. Next slide. Yeah. So what are some of the requirements for safe pediatric induction? As we can see, these are very special patients, and we've just touched on just a few important things. There are several other things that we can look at if we look at other organs. Okay, if we look at the homeostasis mechanisms, yeah, So they are very special patients, and therefore we have a lot of consideration in terms of requirements that are needed before inducing them, during anesthesia, and also after, in the post-op period when we awaken them. That is if we are dealing with surgical interventions. So before we induce pediatric patients, we must make sure we know what's going on with these patients. And by that, I mean, we must know the history, all right? How did it starts from way back at the time they were born? That's the information that we want to have. At what stage were they born? Sometimes, depending on certain circumstances, we even ask what was happening before the child was born, when the mother was pregnant. Did she get an infection? Did she experience any form of insult to her pregnancy? So it starts from there. Up to the time they are born, we ask how everything went. Have they been having any sicknesses? So an overall history. And as you've seen, it's quite a very comprehensive history that we need to get. Yeah. But I should mention that, of course, we can't ask a baby, we can't ask a pediatric patient, even a 5-year-old. The things that they will tell us won't particularly be reliable. Yeah, so history is mostly gotten from either the mother or the immediate caregiver. Yeah, so we get medical history, and of course, we need to do a thorough examination on these children. Yeah, so we examine them, and we do necessary lab investigations. So that is in our pre-anesthesia evaluation. Then, if they of course, they're about to undergo a procedure, surgical procedure, we need to make sure that they've fasted. So with children, it's very, very important that we communicate with regards to the time that they should stay without eating or drinking anything. Unlike adults, like where the facility that I am at, with adults, we actually, it's almost like standard. We tell them don't eat maybe from 5 a.m. and maybe sometimes we say from midnight, don't eat anything. With children, it's not supposed to be done that way. With children, we must actually calculate. So we must time to say, okay, the surgery is happening at this time, and therefore this child should only starve from this time. Yeah. And this is because what I've already mentioned, their increased demand, because they are growing, they need energy. We can't afford to not give them energy. Yeah, it will definitely disturb them. So there are guidelines for fasting. Mostly people follow different guidelines, but of course there are standard guidelines for fasting. One of them that is adopted by the UK is that for clear fluids, a child can take like 2 hours before surgery. Yeah, so they should only fast after they take fluids, clear fluids. They can only stay 2 hours before you take the meal. Yeah. For milk, which most of our patients take in this population, breast milk, we give them 4 hours. Yeah. Then for solid foods, 6 hours. Just like in adults. Yeah. And the other reason for really paying attention to fasting, it's just like that in adults. We want to prevent them aspirating. So the food coming from their stomach going into the airway. We already mentioned that the airway is very narrow. And so even just food substances would actually go and block and compromise. And not just that, I think the most important thing is the acid that is in the stomach. If it goes in the airway and causes swelling because it's acid, the swelling, just minimal swelling, would completely compromise their airway. So it's very, very important that we pay attention to this. Yeah. Yeah. So like I mentioned, consent is gotten from the parent or the guardian. And in the pre-induction period, requires very good preparation. Yeah. So so it's not just preparation on our part, it's preparation on the parent as well. Yeah, so we have to really explain what is going to happen, what is happening at the time, and what's going to happen in theater to the parent, and sometimes to the child, if it's indeed a bigger child. So it's very important. So we have to offer emotional support. In some centers, parents are actually allowed to be in theater. Yes, of course, depending on whether they agree or not, we can allow them to be close to the child. This is also part of our preparation. So sometimes we would ask them for certain procedures. Yeah, and it also gives the child, it adds on to the emotional support on the child and sees that a very familiar face is around. Yeah. Next slide. Yeah. Then when it comes to now the planning, like how are we going to induce this child? I think the first thing is what drug are we going to use? Yeah. But I should say that before we even think about all this, we should make sure, of course, I will talk about it. We should make sure that everything is ready. Yeah. All the emergency drugs, we must make sure that we've put into consideration the age of the child, the weight, everything is ready. Yeah. So before we make a plan. So choice of induction drug. The choices depend on so many factors. So they will depend on the age of the child. A newborn, someone just born today, there are certain drugs that you don't want to give, or if you are to give them, you actually give them in very minimal volumes, right? So overall in anesthesia, there are two groups of induction drugs that we use. So we can use gases, or we can use the IV drugs, the injections. So we can use IV or the gas. And so the choice depends on one, the procedure that we're doing, the type of child that we have, the weight of the child, the medical condition that they have, and sometimes what is available, like in a resource limited facility. Sometimes what is available also just determine what you're going to use. But we have drugs, the most commonly used are propofol, and which are the IV drugs, and Civo, which is the inhalational drug, the gas. Yeah. And of course, we have to know how much we should give them. Okay. So the amount that we give them is not determined when the child is already on the table. No, it should be calculated prior. Before the patient even comes to theater, everything should be ready. So the amount of drugs should be calculated based on the weight of the patient. Yeah. And there are, in certain circumstances, with experience, other drugs would actually be given in relatively lower doses, especially drugs like opioids for analgesia. Sometimes we actually lessen the dose a bit depending on how the child is. Yeah. Yeah. Then, of course, monitoring. Before we even give these patients to these drugs to these patients, we must make sure we know their baseline or the functional status. And one way of getting an idea of what's going on is by monitoring them, by establishing their baseline heart rate. We want to know before interventions, what is this child's heart rate like? We want to know their electrical activity. We want to know whether they are hypoxic before starting, right? So we do monitoring. So standard monitoring like oxygen monitoring, we monitor the heart electrical activity, we monitor the heart rate, very, very important, and blood pressure. Yeah. But of course, sometimes we do even monitor the respiratory rate. We want to know how is the baby breathing, and not sometimes, always. It is important as we connect the ECG. It will tell us how much the respiratory rate is based on how the chest is moving. So we want to know that before starting, because it will help us interpret what will come after, especially in the post-op period. Yeah. Yeah, then of course airway management, so preparation of the airway. So all the necessary airway equipment should be there. In most centers, it is actually it's protocol that there is a set of pediatric instruments readily available, all sizes and all types of airway equipment that can be used during induction should be available. Yeah. Okay, next slide, please. Yeah. So in terms of air equipment, so as you can see in that picture, some air equipment that have been projected, including the scopes, laryngoscopes, of course, the tubes, the Gardel, several types of airway equipment. And as you've seen in that picture, there are different sizes that are there. Yeah. So sometimes it's sometimes difficult to estimate the size before the patient comes. Yeah, because you might have a 3-year-old, one 3-year-old who's actually relatively larger than another 3-year-old. So these are really not based on the age, the instruments. So sometimes they are some of the instrument that is they are based on the size. Okay, so the weight of the patient. So the most important one, of course, being the tube. Okay, the size of the tube, the endotracheal tube that we're going to use if we are to intubate this patient. So there is a way of determining. Of course, the determination is not exact; it's an estimate. So the estimate is that you get the age of the child, you divide by 4, then you add 4. So age divided by 4 plus 4. So that would be the estimate of the age of the child. But this formula works with children that are like 2 years and more. Yeah, those that are less than 2 years, in most hospitals, there will be guidelines on which size to use, like for newborns. Yeah, like a newborn that was born at a normal weight, you can use like a 3.5, sometimes a 3. Yeah. And yeah, so it's always important, if you are not sure, to go back to principles. And this time with our technology, it's very easy. Yeah, with some websites, especially those that I've got things to do with our practice. You can actually just go there, just a click or two, you get a chart and you'll be able to estimate. Like I've said, it's an estimation. And so when you have these instruments like endotracheal tube, you need to have different sizes, all right? So that if you start with probably something that is larger and you have difficulties, you don't have to waste time. Yeah, because we've already said that these are prone to hypoxia. So quickly get another one, of course, with assistance, and be able to intubate them. So you should have at least, standard is that you estimate the normal. Okay, for this kid, I'll use a 4.5. What you want is to have a 4 available and probably a 5. Yeah. And for me, like how I do it, I'll even get like a 3.5. Yeah, like even something that is even way smaller, in case I run into problems and the baby just the airway gets like too close, the baby develops anaphylaxis and all that. So I make sure I like have everything. And like I said, it's very, very important that you have all the instruments available within the theater. Don't have a situation where you give drugs to a patient, then you start moving around looking for a good sized tube. Yeah. So on instrument that is, yeah. Then we have other instruments that will help with maintaining patterns of the airway, like the Gardel. You can do sizing, which is mostly done from the angle of the mandible to the corner of the mouth. Yeah, that is for the oral pharyngeal airway. Then you've got a nasopharyngeal airway, which is determined from the tragus of the ear to the nostril. Yeah, so that is how you determine the size. That's how you estimate the size of some of these instruments. For the LMAs, yeah, the laryngomask airways, these ones are labeled. Mostly they will have a range based on the weight of the patient. So there will be a label on it to say, okay, this one will go in someone who's maybe between 10 kg and 20 kg, and just like that. So you are guided that way. But what's important is that you need to have all the necessary instruments that will help you manage the airway. Yeah. So in addition to this, the anesthetic machine. The anesthetic machine should not be prepared or in short set when the patient is in theater. No, it should be preset before the patient comes. So of course, as you are pre-assessing the patient, you would have gotten the weight of the patient. And so things like the volume that you're going to use, the pressures and all that will be guided by the weight of the patient that is coming. So you need to make sure the anesthetic machine is already set. You need to make sure you have oxygen in theater. You should have tested the machine and making sure that it's working. You should also have a backup just in case this machine becomes faulty or something. You need to have backup for oxygen and a way of ventilating the patient. So that is important. Yeah. Monitoring equipment, which I've already mentioned, should always be available. You can't do procedure on a child with just a pulse oximeter. It's substandard care. So for a child, every child that is undergoing and that's about to undergo induction, all the basic monitoring has to be there. All right. Okay, next slide, please. Yeah. So what about the personnel, the people that are intervening? Yeah, I know this might be a bit difficult in some resource limited facilities where you don't have specialists, and that I'm talking about pediatric anesthesiologists. But because these are very special patients, they need someone with very good experience, someone with very good understanding about a pediatric population. And what we mean is a pediatric anesthesiologist should be available. If the pediatric anesthesiologist is not available, at least you must have a senior available who is more experienced in case you run into problems. Yeah. So they should be present. Sometimes it's not really that they will intervene. Sometimes they're just there for supervision to make sure that what is everything that is being done is correct. Yeah. So one can't work alone, of course. An anesthesiologist can't work alone. You are pre-assessing a patient. You should have already given orders to your assistants to make sure that they set the machine, they make sure all the equipment is available in theater. So you need anesthesia technicians to be there. The nursing staff should also be informed. So all the people should know what is going on, what the weight of the patient is, what the condition is, what will be done, what's expected, what are some of the anticipated complications that can occur. And that is not just on the patient, but in theater. Is the theater safe for this procedure? All right. So communication will be very, very key. So you can't start a procedure without doing a WHO checklist. Yeah. So we must make sure everything is there and good monitoring and everything. And in addition to this, if we don't have a senior available, at least they should be well informed so that in case we need them, we can quickly get them to come in and be able to help. Yeah. Next slide, please. Yeah, then when it comes to safety, like I mentioned, we must make sure that the theater that we are using, the environment we are using when inducing this child is safe. So part of WHO checklist is making sure that we are dealing with the correct patient. The patient has been identified. We must make sure that the parents or the caregivers are aware that this child has been gotten from them. You can't just go to the ward because the patient is on the list. You get them, you bring them to theater and work on them without the parent knowing, especially in children that are in like high dependence unit like PQ. Sometimes parents are not allowed, especially for bigger children. And if the parent is aware and the time for a surgical procedure has come, you can't go and just get them. Yeah, sometimes you have to wait for the parent to come. If you can't, it's an emergency, you have to find a way of communicating with them. Yeah. So it is very important. So we must make sure that we know what we are dealing with, the patients that we are dealing with, and we are aware that the patient knows. This will prevent errors, of course. Yeah, emergency equipment should be available. Like I said, defibrillators or the emergency drugs, emergency trolley has to be available all the time. So in every theater, of course, there should be safety, not just for the patient, but for everyone who's working there. So that includes fire safety and also infection. Yeah, and so there should be protocols for any operating theater. There should be a protocol for what everyone is expected to do in case there's a fire breakout in theater. Yeah. And so infection prevention, as well as we've already said, these are immature populations there. Their immunity is not as strong as well. So we must make sure that infection prevention measures are there. Okay, next slide. Yeah, so documentation, of course, in the pre-assessment, you should have already documented everything. Yeah. In case there are issues, you can still go back and say, okay, this was already identified and everything was done. An anesthetic plan should have been done before induction, knowing which drugs you're going to give, how much you're going to give, and all that. Then monitoring was obviously being done. You must, if you are not alone, you must make sure you've identified someone who's going to be giving the drugs. You must anticipate complications and be ready to handle them. Yeah. And of course, in the post-op period, you must manage the patient. It doesn't end on induction and managing. In the post-op, sometimes we even have to follow them to the ward and manage their pain, yeah, and manage all the possible complications that can occur. Yeah. 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 So I think I'll end there. Thank you very much.
Thank you very much, Dr. Jerry, for that wonderful presentation. Am I audible?
Yes, you are.
Yes, we can hear you.
Thank you. Thank you. Thank you. Thank you very much, Dr. Jerry, for that wonderful presentation. Very detailed indeed. At this point, I'm going to invite Dr. Faiza, who's going to take us through the second part. I also want to inform our participants that they can use the Q&A for questions that they would like the panelists or the presenter to attend to at the end of the presentation. Thank you. Dr. Faiza, the floor is yours.
Okay, thank you. It's my pleasure to be here. And I will try to go fast as much as possible through the options of induction in pediatric age group in Anaesthesia. The next slide. So generally, we have two options on induction, the inhalational and IV means of induction. I'm sure all of you are aware of it. And it depends on different factors when you choose between the two. And you can see and look at your setup and plan as your environment, because different setups, they got their own principles or means of induction, either IV or inhalational. The next, please. So to choose between this, the options, you have different factors to consider. The first thing is whether the baby is having IV access or not, and the availability of the inhalational induction, which usually be used like sevoflurane. And I hope it's not really available in all setups. So this is one of the factors will determine whether you are going to induce by inhalational or IV. And the other is whether the baby is cooperative with you or not. And these things you'll decide when you do your pre-op evaluation majorly. And the other issue is the airway issue. So you can look for the gross abnormalities, any concern you have, and you decide on your options of induction. And the other, as my colleague tried to mention, the availability of personnel who is going to assist you in case there is something happen. So you will see these factors and choose your means of induction. Next, please. And one of the commonly used in pediatric age group is the inhalational anesthetics, which is the sevoflurane. And you all know is chosen as a means of induction because of this good pleasant and hemodynamically it will not cause much derangement. So it can be used as an induction and maintaining general anesthesia both. And as you see on the figure, the dosage usually we start from the high, like 8, and come down as the baby gets deep during induction. And you have all heard about the monitoring. Don't forget to put all ASA standard monitoring guidelines. Don't forget to apply that one anytime, because some of the time some people forget to put monitors. At least pulse oximetry should be put on baby before you do anything, and then you can proceed with the other monitors while the baby is getting deep on inhalational induction. And next, please. And as I've tried to say, you can see on this figure, choose the appropriate size face mask, especially when you choose inhalational anesthetic as your means of induction. See, it should be at the bridge of the nose and covering the border of the mandible and the mental. Then it should cover both the mouth and the nose, so it should be properly fit for the child. Here, we don't really depend on the size of or the number indicated on the face mask. We rather see the baby and choose the size of face mask really fit for the child. And some of the time we'll allow the parents to come in with the children to the theater, but it depends on the child you are taking care of. If they are really cooperative and interacting with you and you can easily handle them, there is no need to bring parents in theater. And if they are really anxious and you think they need the parents with them, you can allow them and smoothly induce the babies, especially for inhalational one. Next, please. And the other option is intravenous induction. This usually works if the baby is having IV in place before coming to theater. And the other, if they are really big pediatric age group and they are cooperative with you. And if sometimes they prefer to be induced with IV if you are really communicate with them. And if you become friendly with them, they will allow you to put IV line and induce with IV induction agents. So it depends on the presence of IV line in place before they come to theater and the age of the child, those adolescents and bigger babies. And the commonly used one, as you are aware, is propofol, and it still depends on the hemodynamic stability of the specific child. So it's not a routine to use propofol for all medical conditions or any associated hemodynamic instabilities. So you choose depending on the child you are with. Next. And as you use this IV induction agents, you need to titrate. Usually there are common dosage as per kilogram. And on the depths of anesthesia you want and the presence of any comorbidities. So you have to titrate the dose of the drugs. Usually there are children who are susceptible for certain dose of drugs. So let the child be the guiding book for you rather than the mere indicated milligram per kg or microgram per kg. So depend on the children or the pediatric age group you are playing with or you are taking care of them. And there are other means of administration along with IV, like intranasal and transmucosal. Instead of the other ones, you can also add this as a means of supplementation. And The proper selection of medication, as I've tried to say, depends on dosage, the techniques you use for administration, and the monitoring you are looking at, like the BPs and the others. So it will guide you also. Next, please. And there are other adjuvants and analgesics you use along with commonly used intravenous induction agents like NSAIDs and opioids, or like antiemetics. So you can reduce especially the dose of the drugs you are commonly using, the hypnotics, so that will reduce the volume and the concentration of drugs you are going to use, both in IV and inhalation also. So there are also local anesthetics you use for analgesic purpose as a means of filtration or nerve block. And also benzodiazepines, commonly used one is a midazolam, because it will reduce anxiety, and also the dose of drugs used for induction as a general anesthesia. And next. And here is a scenario for you to meditate how you approach for babies. Is a 5-year-old girl who presents for herniatomy in your clinic during your pre-anesthesia review and the program. And both the mother and child, they're attending or they're with you during your evaluation. And you take the baby to the theater along with the parents, and then how do you proceed in the theater? How do you induce this child? Because some of the time there are age groups who are really confusing, like school age groups 5 to 8, like this. They are really, when you approach them while they are with their parents, they look sociable and okay. When they are separated from the family, they feel anxiety, and they will be uncooperative when they are in the theater. So you assess this while you are doing your preoperative evaluation. So you can take the parents along with the baby and induce the child depending on the scenario you are in. And I don't want to take time because we are running out of time. I don't want anyone to respond or interact. It's okay, we can proceed. Next. And as Dr. Jerry tried to mention, this is a recap almost. During your preoperative evaluation, you need to see for the medical history assessment, risk, the risk you have, and the physical exam, laboratory investigation. All this should be reviewed in detail, because it's the time for you and for the family and the patient. You will have time to plan and decide on the post-operative plans, and all should take place when you do your preoperative evaluation and assessment. And next slide is a continuum of this preoperative evaluation. So is this next, please, will go. So here again, the NPO guideline, because there are different challenges when you do your preoperative evaluation regarding operative fasting. Almost all children, they are really over fasted. So you really need to take care of this scenario, because in drop, when you try to access the IV and hemodynamic perspective, there will be hypotensive because of prolonged starvation. So you need to give attention for fasting guidelines. We need to be strict with the guideline. And the other issue is the psychological preparation. Both the family and the parent, the patient, the baby, they will be prepared well when they get you. Anesthesia is not the mere documentation of the finding and the like. It's also encompass preparing the parents psychologically for the procedure. And the informing consent, as you all are aware, the babies will not give you a consent. It is, after all, the parents are going to give you all the details or the legal guardian before you proceed to any anesthetic procedure. Next, please. And there are other debating area regarding the pre-medication issue for children, especially before you proceed with any sort of induction. There are pros and cons regarding this issue. The positive side is the baby, if they are really they're anxious, they will be calm, and this pre-medication also will reduce the amount and dosage of the drugs you are going to use. And at the same time, the problem associated with this is if the baby is uncooperative and having some airway issues, and there is any comorbid conditions which will affect when you give a pre-medication, they will be at risk for different complications. So it depends on the way you are going to approach these babies and the clinical condition of the patient. So nowadays is said to be, it's not routine to give pre-medication. Rather, you can choose the other options like bringing the parents into the theater with the baby and using different methods like videos or toys and like the others, so that you will make the induction smooth rather than giving pre-medication. Next, please. And this is the way we try to make a friendly approach during induction and make it smooth. And some of the children, they have their own face mask at home, and you can ask the parent, the family, and they can bring into the theater with a child, and you can, as much as possible, it's good to be friendly with children preoperatively, so that they'll think as a family, they'll think you as taking care of them, so you will make things smooth and going well intraoperatively and during induction. And there are different drugs you use, like alpha-2 adrenal receptor agonists like dexmedetomidine and clonidine. This is used for like sedative purpose, for anxiolysis, and for reduction of anesthetic requirements. So even for post-op complication managements like delirium or agitation, they will help you in reducing these complications. So you can use these drugs as additive ones during your induction. Next, please. And the other issue is issue regarding patients at risk for aspiration and rapid sequence induction. There is a debating area on using rapid sequence induction and place of cricoid pressure, especially for tiny babies and neonates, because it's said to be hinder visualization of the airway and like that. So, but you'll prefer just putting pressure or using rapid sequence induction if the babies are really at risk for vomiting or aspiration, and if the operation is an emergency and you think you have a good staff or personnel who can smoothly take care of the airway, and you can still use the procedure. Next, please. And the common challenge for pediatrics induction as we try to see, is a summary or recap of what we have been talking so far. Babies are uncooperative and they are anxious when they are separated from the parents. The issue of vascular access, especially for babies with syndromic like Down syndrome, that's really challenging to access the IV lines, and those who are dehydrated or hypovolemic, they are really at risk, and the skin color even will put you at risk or will challenge you in accessing the IV line. And the need for more help also is a challenge during pediatric induction. You need more personnel who is trained in pediatric anesthesia. If not the senior one, as my colleague tried to mention in the previous slides. And the risk of adverse events is high than the adults or a bigger pediatric age group even. And inadequate resources, especially in low and middle income countries, is a common challenge because of different poor setups and inadequate resource. You will face challenges of monitoring is one of them. So we need to have this as a common challenge. Next, please. And as a general, the recommendation for all is pre-assessing, like we do pre-evaluation, pre-operative evaluation, planning according to the patient, and prepare yourself depending on the case or the patient and the participation. Try to involve all the seniors and the human resource you have along with you, and pay attention to the details of the case you are having. And you see the 10 N's for the quality of pediatric anesthesia, induction, and all the monitoring intraoperative and postoperative, the 10 N's, you can look through them. It's okay. It's okay. Continue. So lastly, the reference we are using, and thank you. If you have any questions and comments, you are welcome. Thank you.
Thank you very much, Dr. Faisal. I would like to say thank you to both presenters. They are all fellows in pediatric. Dr. Jerry is a fellow in pediatric at UTH in Zambia, and Dr. Faisal is a fellow in pediatric anesthesia at University of Nairobi in Kenya. It was a nice presentation. At this point, I will not take long. I will ask one of the panelists if they have any comments to make over this presentation. Dr. Ndaba, are you there? You can make any comment? We can also take opportunity to answer one of the questions, the Q&A.
Yeah, thank you so much, the moderator. Just to confirm if you can hear me.
You are audible.
Yeah, thank you so much indeed to the two presenters. I think that was excellent. You've really simplified a lot of complex concepts for us. Indeed, we have something to take home from the great presentation that you've made. I just wanted to quickly zoom in on the issue of pre-medication, and I would comment based on my own personal experience in practice. The issue of pre-medication, I think one of the presenters mentioned that it's an institutional issue. Certain institutions do actually practice, pre-medication, especially targeting on the issue of anxiety and dealing with the apprehensive and uncooperative child before induction of anesthesia. So I think it's true that pre-medication to sort of kill anxiety is institutionalized. Personally, I don't usually give any pharmacological interventions, like other facilities would consider things like midazolam, either orally or IV or IM. Others would give a small dose of ketamine, IV or IM, before the child actually gets induced. Others would consider other drugs. I think personally, we do the non-pharmacological kind of intervention, where we really want to focus on reducing the time between the child being with a parent, where they are calm and cooperative, and induction. Yeah, so we really want to make that period as short as possible, because remember, a child who's apprehensive, who's distressed, sometimes can disturb or can be very distressing even to the theater team. So we try as much as possible to reduce that time between induction and also the child being away from the mother. We also use some of the distractive techniques. Sometimes it could be a phone. You know, kids these days like phones. You can use a phone and maybe pick one of the common cartoons, so that you just get them to cooperate as they detach from the parent. And indeed, there are other visual techniques that we've also adopted in theater, just to try and calm the child as we prepare to induce the child. And all things being equal, our most preferred form of induction would be inhalational, and then the second option is IV induction, with or without a cannula. So I thought of just sharing that personal experience, but I know other facilities do routinely practice the administration of pre-medications to kill off anxiety. Thank you so much, Dr. Papicho. Over to you.
Thank you very much for that wonderful comments and sharing your personal experience. Dr. Sweetbert, will you have something to add up?
Thank you, Papicho, and the presenter. I think it was one of the very good one we have done. So I have nothing. I think everything has been said. I think the most important thing which I will add is I'm sure each hospital, they have their own protocol. So what we just presented is just an overview. So for when it comes to pediatric, we know they're very sensitive. I will advise each hospital to stick on their standards, so make sure the kids are very safe. Otherwise, thank you very much. Everything has been said.
Thank you very much, our panelists. Thank you very much to our presenters. There's one question in the Q&A. Maybe Dr. Ndaba, will you want to pick it up? Since you made a comment on the premedication, this is also related to premedication.
Yeah, I think just connecting to my earlier comment on the use of midazolam for pre-medication, there are the different classes of drugs that can be used. One of the classes is benzodiazepine.
Oh, sorry. It seems like we've lost Dr. Ndaba on the call. Dr. Ndaba, are you still there?
We've lost him.
Okay. Dr. Ndaba is gone. We've lost it. Time for him to come back. Any comment from you, Dr. Sweetbert, on the same question? Or our presenter, Dr. Jerry? Any comment on the question?
Okay, let me say something regarding midazolam. as one of the benzodiazepine and using as a means for pre-medication. We can use in different forms, even orally or IV means, but still it's just an area of debate, as I've tried to mention, and we need to be careful when we do this. We need to see the patients in detail, and the distance from a theater to the area, waiting area, should be minimal. If we are going to use, if it's a last decision or a last resort as a means of taking the baby to the theater. Otherwise, I don't really agree to usually as a routine using a pre-medication. That's also my perspective. I used to do that when before I joined this fellowship. In our setup, we were using like ketamine and midazolam as a pre-medication means. But after I joined and I saw things, I really changed my mind. So I really agree with using non-pharmacological means for pre-medication, for taking the babies to the theater. Because sometimes we don't know, we will have unexpected difficult airways and will end up with chaos. So I don't think it should be a routine means of taking the babies to theater. That's my perspective.
Thank you very much, Dr. Faiza. I think that answers the question from our colleague. And I guess there's no more question pending. At this point, I would like to invite Mariam or Magdalena to make the final comments. Thank you.
Hello all. Mine is to just thank you for joining, and thank you, Dr. Jerry and Dr. Faizia, for the great presentation, for the great exchange in ideas in ideas in the pediatric anesthesia. We just want to let you know that a Gradient Health System is an organization that is a social enterprise that focuses on anesthesia and critical care, especially access in low and middle income areas. We have our machines, the universal anesthesia machine, the ICV, the ventilator, and also an upcoming machine called the KO2, and also the Prima for anesthesia. So we want to really thank you, and feel free to join our to reach out to us or using the customers@gradienthealth.org. Give us your feedback and any topics you'd like us to discuss. We really thank you and we value your time. Thank you for spending time with us. Yeah.
Thank you all for having me and for giving me the opportunity. Thank you very much.
Thank you for this opportunity, everyone.
Thank you all for coming through. Until next, we say goodbye. Thank you.